So greetings and welcome to everyone, our two panelists and our attendees to this WOW webinar. Wellbeing of Women runs a webinar every month, and I promise you that it's going to be recorded. We range from topic to topic. Nothing is too secret, too shameful, too stigmatized for us to be discussing on this platform. And our membership and our attendee list is growing and growing. So please come and be part of the family. By tomorrow, you'll be able to access the recording on YouTube if you've missed it or you want to revisit it. Usual webinar housekeeping rules. We're recording this. Please use the chat function for comments and questions. We welcome them throughout, and because I'll be busy talking to our two specialist panelists today, the wellbeing team who are behind the scenes will be keeping an eye on the questions and then prompting me if there's some that are coming up repeatedly. And before I go on to introduce our two fabulous speakers today, I want to thank our sponsors, Financial Services Compensation Scheme and Bolt Burden Kemp. I can tell you as the chair of Wellbeing of Women that these webinars are reaching an enormous number of people, and they really are of great benefit. And the fact that we can archive them and everyone can access them at a later date at their leisure or to review them, I think is a great bonus. So I'm going to introduce firstly Nafisa Anwar. And Nafisa is a nurse midwife, and she's got over 38 years experience across a wide range of health-related and women's health issues. Nafisa has developed a really strong passion for inequalities in health, especially in maternity services, and she's been very driven to influence and initiate change in the healthcare systems, not just in the UK, but also in the developing world. And that's something that I've always been very interested in my career as well, learning from other countries and realizing that developing countries can often teach us a thing or two because they've had to go about things in a slightly different way. She's a member for the Embrace Perinatal Confidential Inquiry and also a member of the Capital Midwife EDI Advisory Group. And in her NHS role, she's the lead maternal medicine midwife for North East London, and she was integral in developing the maternal medicine service across North East London. She's very proud, and rightly so, of being awarded the RCM Fellowship in 2022, and I think we met at that time because I was at the ceremony, and she's recently secured the prestigious Florence Nightingale Leadership Scholarship. And then, as you know, in these webinars, we always want to talk to women with lived experience. And so it's enormously pleasurable for me to introduce Geeta Nayar, who I seem to be spending rather a lot of time with recently. We keep going to conferences together, whether they be in Birmingham or in London. But she's a senior associate solicitor at Irwin Mitchell, the Mazik Foundation and Birth Trauma Association. And I'm not going to steal her thunder, but if I was to just summarize by saying that her life took a rather dramatic turn during the birth of her first child, Maya, back in 2008. So not 2018, 2008. And she's going to tell us the story about how suffering from an obstetric-anal sphincter injury and post-traumatic stress disorder, that her health and her career and family suddenly went into a spiral. And she's going to tell us about her experience and how she's gone about getting back on track, shall we say. And I think she's going to particularly focus on the things that employers and friends and colleagues and family members can do to help women in this situation. And why I say that is we know that, everyone on this platform will know that birth trauma has been hitting the headlines recently with the very dramatic report that came out about a month ago now and was launched in Parliament, and I attended that event. Thousands of women are now coming forward to describe the debilitating psychological and physical and societal impacts of traumatic births on their lives and the lives of their families and the people that they're closest to. It's been estimated now that 30,000 women develop PTSD every year because of a stressful or a distressing event related to childbirth, and many find themselves recovering from birth injuries, which can be quite life-threatening or result in chronic pain, incontinence, infertility. So it's marvellous to have got these two women with me today who really have championed this field. And without further ado, I'm going to turn to Geeta and ask her to share with us her birth story and the trauma she experienced and what happened to her in those very, very painful and difficult and stressful weeks and months post her birth. So please, you carry on, Geeta, because you tell your story very beautifully. I know, because I've heard you do so. And I know that our audience are thrilled that you're here too.
Thank you so much, Dame Leslie. I hope everyone can hear me. Great. I want to share with you today my lived experience to give you an insight into the devastating impact of birth trauma and the challenges women face to get adequate support. The injuries I sustained, both physically and psychologically, during the birth of my first child, Maya, still impact me every day. That was 16 years ago. I was 30, at the height of my career as a serious injury lawyer. I was recently married and excited about becoming a mother and what the future held. I'd read all the books and prepared my birth plan. I thought I was as well prepared as any first-time mother could be. But vitally, what no one had discussed with me was my personal increased risk of perineal trauma. South Asian women have the highest risk of 3rd and 4th degree perineal injuries. I went into labour on a Sunday night at a busy teaching hospital. I felt supported and appreciated the care I was being given. However, as evening approached, there was a 7 p.m. changeover of staff, and it was at this point things started to deteriorate. I often wondered what was discussed at that handover or whether there was something in my notes. Perhaps this young woman was exhausted herself, but from the minute my new attending midwife came on shift, she had an inexplicably hostile attitude towards us. I'd stopped dilating at this point, was exhausted, in pain, and it was clear things were not going to plan. My mother, a paediatrician, was with me, as well as my husband, Ed. But any requests to discuss the deteriorating situation were just met with increased irritability. The tension in the room was palpable. We couldn't speak about our concerns, and any attempt to ask to speak to the registrar on duty was met with a brusque and snappy response. The staff were busy. There was no need to bother them. We were scared, felt isolated, and increasingly worried. When we did eventually speak to the registrar and expressed our genuine concern at the decelerations on the trace, that I would like to discuss being moved to theatre, I was patted on my shoulder and told not to make. Still clearly remember those words to this day. Eventually, there was marked fetal distress. Panic ensued. Suddenly, the room was filled with people. They had to get this baby out. There were several failed attempts at ventouse, and then an extremely traumatic forceps delivery that left my daughter with permanent facial injuries, and I sustained a 3C tear involving the entire length of the external and internal anal sphincter. I was unable to hold my daughter Maya, and I was taken to theatre for hours for an attempted repair. I was then left on the postnatal ward alone, traumatized, in pain, and unable to even pick my daughter up to feed her. My repair failed, and I experienced my first episode of fecal incontinence the very next day. From this first episode to date, I continue to be permanently incontinent of feces and flatus, have marked fecal urgency, passive fecal incontinence, urinary incontinence, dyspareunia, and perineal pain. I was in complete shock at the traumatic delivery I'd been through and was solely focused on the injuries to my daughter, so I had no idea how severe my injuries were. I can clearly recall leaving the hospital in agony and all of us just utterly distressed. The yellow nursery I'd painted and organic cotton sheets meant nothing. I was in shock, simply unable to process what I'd been through. In the days that followed, we struggled with feeding due to the injuries my daughter sustained. We later discovered she had a fracture of the zygomatic arch. She also developed jaundice, but neither my health visitor or GP were aware that it was harder to detect due to the colour of her skin. And by the time it was realised, we had to be urgently rushed back into the same hospital for several nights, which only compounded the trauma. As it was, those first few weeks and months were as far apart from how I had envisaged them. Instead of walks in the park and meeting up with friends to introduce them to our new baby, I was having regular and severe episodes of incontinence, was pretty much housebound, and was suffering from what I now know was postnatal post-traumatic stress disorder. I struggled to hear my friends' birthing stories or see pictures of their babies. I couldn't drive past the hospital where I gave birth. It was all so triggering. I would lie awake in between those nighttime feeds, thinking about her again. Why had no one listened to us? And I had huge guilt at not being able to protect my daughter. I was at my most vulnerable, having my first child and knowing things weren't going well, in pain, exhausted, and yet we were dismissed for reasons I couldn't understand and still can't. I had absolutely no sense of control of what was happening and was just desperately worried about my safety and the safety of my child. Being in this situation and being treated without compassion, feeling totally helpless, is a really common theme and cause of birth trauma for many of the women I've met through my involvement with the Mazik Foundation, which is the only charity to support women with obstetric anal sphincter injury. I saw my GP several times. He was empathetic and he was shocked at what I'd been through and at my symptoms, but he never had any answers. 16 years ago, I don't think he was probably aware of a perineal trauma pathway. I know a lot of the pain I experienced, both physically and psychologically, may have been reduced had I been referred on to the right services early on. The only place I was actually referred to was Urogynae, and I was simply told to do pelvic floor exercises. I went from being a resilient, independent woman to needing significant help, particularly from my husband, in pain, having frequent bowel accidents, and it only compounded my feelings of sadness and also horror at what had taken place. I struggled on, but after several months, the situation was so dire, I moved in with my parents for support. I'm from a family of resilient, high-achieving women, so the fact that I could not cope with the severity of my symptoms and being a new mother made me feel like an abject failure. Every time I spoke to a healthcare professional about my injuries, but there was no help offered, it only served to reinforce my feelings of helplessness. So eventually, I just gave up. It was only because of circumstance that I managed to get help. My mother researched and really pushed for me to get a referral to a perineal trauma clinic. Finally, only once I underwent extensive endoanal investigations, I was told for the first time how serious my injuries were, involving pudendal neuropathy, and that my poorly attempted primary repair had failed. It was horrifying to hear, but also, to be honest, it was a relief to finally understand why my symptoms were so severe and debilitating. I also managed to eventually access the psychological support I needed and EMDR for trauma therapy. It was like having a huge weight lifted to again understand why I had been so badly affected by my traumatic birth. Birth trauma impacts self-esteem, the ability to socialize and work, physical intimacy, social isolation, economic deprivation, and comorbidity of psychosocial problems such as depression, anxiety, stigma, taboo are all widely reported. In fact, the Mazik survey found that 85% of women who they surveyed who sustained severe perineal injury and birth trauma said it impacted on their relationship with their child. Since then, I've undergone further surgery, rectal washouts, medications, biofeedbacks, the works, but I've simply had to adjust the way I live to cope. I have lost precious years of normality, and the ripple effect on my family, especially my husband, who's had to provide so much support to me, has been huge. But I actually feel like I'm still one of the lucky ones, and my story has a silver lining. I had, as I said, amazing support from my family and my friends. Not everybody has that. And after over a decade, I've rejoined my firm, Owen Mitchell, fully supported and to work alongside my genuinely dedicated colleagues, healthcare professionals, policymakers, and community groups with a focus on maternal safety and improving outcomes. On Friday, I was proud to have the support of both Dame Leslie and Nafisa at the inaugural South Asian Maternal Health Conference, focusing on safer and equitable maternal outcomes for all women. Thank you very much.
Well, I'm sure I speak for everybody on the platform when I say, Geeta, thank you for sharing it's a testimony with us, and congratulations on being able to do it in such a composed way. It must give you flashbacks even as you're thinking about those things. And one of the things I thought about what would have affected me so much, I think, is this feeling of not being able to protect your child when she had these facial injuries as well. And you mentioned about how so often these problems can affect the relationship with the child that is born. Do you want to say a little bit more about that?
Yes, so personally, I mean, it's one of the things that, I feel very lucky about, that I, didn't have a problem bonding with Maya. But actually for me, it went the other way, Leslie. I became quite obsessive about her and her health. So I would kind of, listen outside her room to hear if she was breathing. I think that forms all part of the trauma. But yes, there are many women that I've met through my work with the Mazik Foundation or Birth Trauma Association who have been profoundly affected in other ways and haven't been able to bond with their child as well, or they find that their child's birthday is particularly triggering for them. It brings back a lot of the trauma. They relive again a lot of the pain and hurt that they've been through. And also, there's a lot of women I know that unfortunately, Leslie, have not been able to go on to have other children. They found the experience so traumatic that, that they just haven't been able to go on to have more children, which is, so sad. I mean, if their plan in life, you have a plan in life, and then for it to be so seriously impacted, it's devastating. And then also, with relationship breaks down as well. I've seen many women who unfortunately their relationships have broken down because it's very difficult to deal with the aftermath of birth trauma, but as well if there's physical injuries. So for example, with perineal trauma, extensive scar tissue, you can have bowel incontinence, you can have fistulas, pelvic organ prolapse. So returning to a physical relationship can be extremely difficult. And as I say, 16 years later, I still experience, dyspareunia. But I'm very, very fortunate that I have, an extremely supportive husband and family around me.
And I'm so glad you've mentioned that about dyspareunia, because I'm afraid that still there are taboos for many women to talk about sexual problems. And yet actually, I don't know many human beings who wouldn't like to have a nice sex life. So thank you for bringing that up. And I encourage everybody in the audience to be talking about these things too. It's absolutely devastating. And I still meet women, every clinic that I do, who, when I delve into things or their concerns about having a smear or having an examination, it all comes back to what happened to them during birth. So I think that's really important. And thank you again. There's many compliments in the chat thanking you for your testimony, and women saying that they hadn't yet met somebody else who'd had a 4th degree tear. So we're already forging another community here. I'm going to turn now to Nafisa, And she's going to, with her expertise, help our audience understand exactly what was meant by birth trauma. And also she's going to talk about the main causes. Let's start with that, and then we'll come on to the women who are particularly affected by it, and explain a little bit more about the sort of psychological and physical impact that this obviously had on Geeta. And I think she's described it in such a beautiful way that she's given you a platform, hasn't she, to actually share with our audience all of your expertise. So thank you, Nafisa.
Thank you very much, Dame Leslie, and thank you, Wellbeing of Women, for giving me the opportunity to be here today. Just to mention that, you know, my passion is definitely to improve maternal health outcomes and reducing healthcare inequalities. And today I'm going to, if we could share the slide, sorry. I do have a presentation. Thank you. Go to the second slide, please. Thank you. Yeah, can you see that? Yeah. So, so today I'm going to delve into the multifaceted issue of birth trauma, exploring its main causes, who is affected, and the profound psychological and physical impacts it has on women. I'm going to also look at the disparities faced by women from ethnic minority groups, and drawing on latest evidence from recent reports, and identifying how we urgently need a tailored support and culturally sensitive sort of process to bridge the inequality gap in maternal health. Next slide, please. Okay, so first of all, I think it would be good to have a definition of what birth trauma is. And birth trauma is defined as the physical and psychological harm experienced by a woman during or after childbirth. It encompasses a range of experiences, from medical interventions and complications during labour to inadequate support and disrespectful treatment by healthcare providers. Birth trauma can result in lasting physical injuries, such as severe perineal tears or pelvic floor disorders, and psychological impacts, including post-traumatic stress disorder, anxiety, and depression. And we know that birth trauma, encompassing both physical and psychological harm resulting from childbirth, is influenced by several main causes. And these include unplanned or emergency medical interventions, complications during labour, inadequate emotional support, and disrespectful treatment from healthcare providers. And we know that recent evidence from the Birth Trauma Review and the Embrace UK reports highlights that ethnic minority women, particularly Black and Asian women, face disproportionately higher rates of severe complications and negative outcomes. And we know that from the Embrace report that Black women are 4 times more likely, and Asian women are 2 times more likely to die from childbirth-related complications compared to their white counterparts who underscore significant healthcare inequalities. And we know that, according to the Birth Trauma Association, approximately 30,000 women a year in the UK experience birth trauma, which can be either, as I've said earlier, physical or psychological. And we know, and there was a survey done by the Royal College of Midwives, and they found that around 4% of women reported symptoms consistent with PTSD following childbirth. And the Birth Trauma Association also reports that about 10,000 women annually are affected by PTSD as a direct result of their childbirth experiences. And an NHS study highlighted that 20 to 30% of women describe their birth as traumatic, even if they do not meet the full criteria of PTSD. Next slide, please. So if we look at the main causes of birth trauma, these are multifaceted. And as you know, I've mentioned before, it includes the medical interventions, complications during labour, lack of support, and disrespect from healthcare providers. And we know that unplanned or emergency cesarean sections and instrumental deliveries such as forceps or vacuum extractions are significant contributors to birth trauma. And these interventions, often necessary for the safety of the mother and baby, can be traumatic if not well communicated or if they result in these complications. And we know that a study that was recently published in the British Journal of Obs and Gynae found that women who experienced emergency C-sections reported higher levels of trauma compared to those with planned procedures. Also, we know that complications during labour arise, and things like prolonged labour, fetal distress, and severe perineal tears are among the complications that lead to traumatic birth experiences, and reports have indicated that complications like severe preeclampsia, shoulder dystocia significantly increase the risk of birth trauma. We know also that inadequate emotional support from healthcare providers during labour and delivery can exacerbate feelings of fear and helplessness, contributing to trauma. And again, reports have reported that women who felt unsupported or ignored during childbirth were more likely to report traumatic experiences. Negative interactions with healthcare staff, including neglect, verbal abuse, and dismissive attitudes, are critical factors. And we know that the WHO have highlighted that the impact of disrespect and abuse during childbirth on maternal mental health, emphasizing that such experiences can have lasting traumatic effects. Next slide, please. So, looking at who is affected by birth trauma, and birth trauma we know affects a broad range of individuals, with certain groups being disproportionately impacted due to various risk factors and systemic inequalities. We know that women across all demographics can experience birth trauma, and the incidence of trauma can be linked to unexpected medical interventions, complications during labour, and the overall birth experience. We know that women from ethnic minority women, particularly Black and Asian women, are at a higher risk of experiencing birth trauma. And we know that, as mentioned by Geeta, Asian women are very, much more higher to sustain perinatal pelvic floor injuries compared to other ethnic minorities. And these disparities are attributed to the systemic inequalities in healthcare access, quality of care, and underlying social determinants of health. And we know that women also with previous traumatic experiences, for instance, if they've got a history of trauma, such as previous sexual abuse or domestic violence, are more vulnerable to experiencing birth trauma. And the stress and physical demands of childbirth can really trigger memories of these past trauma and exacerbate the experience. Women also who have experience of complications during pregnancy, such as preeclampsia, gestational diabetes, or preterm labour, are also more likely to have traumatic birth experiences. And these complications likely are to be led to emergency interventions, and those in itself can be distressing and contribute to feelings of trauma. Again, lack of emotional and physical support from partners, family, or healthcare providers during labour really, again, increases the risk of birth trauma. And the absence of supportive network can make the experience more overwhelming and frightening. Looking at teenage mothers and older mums, they are also at higher risk, and we know that teenagers may lack the emotional and psychological maturity to handle the stresses of childbirth, while older mothers may face increased medical risks that complicate the birth process. First-time mums can be particularly susceptible to birth trauma due to the unfamiliarity and unpredictability of the childbirth process. The anxiety and fear associated with the unknown can really heighten the perception of trauma. And again, as I've mentioned earlier, women who go through emergency situations, this really can provide an overwhelming experience and distress. Next slide, please. So, looking at the psychological and physical impact of birth, we know that birth trauma, as I've mentioned earlier, has a long-lasting impact on a woman's psychological and physical health. And understanding these impacts is really crucial for providing effective support and treatment. And some of the psychological impacts are PTSD, or post-traumatic stress disorder, and women, again, who experience birth trauma are at much higher risk of developing PTSD. And these symptoms can include things like flashbacks, nightmares, severe anxiety, having intrusive thoughts about the traumatic birth experience. And we know that disorders found that approximately 3 to 4% of women develop PTSD following childbirth, with higher rates amongst those who experience trauma during delivery. Anxiety and depression is another condition that can be felt, and women may feel overwhelmed, constantly worried, and unable to find joy in everyday activities. And this really, really can impact on their ability to bond with their baby, as we heard from Geeta, and function in daily life. And we know that reports have identified that up to 30% of women who experience a traumatic birth report symptoms of postnatal depression. And we've mentioned as well that bonding and attachment issues, the trauma can interfere with this, and this can lead to attachment disorders where the baby may develop emotional and behavioural issues due to the lack of secure attachment with mum. And again, women often experience feelings of guilt, shame, and failure, especially if the traumatic birth did not go as planned. They might blame themselves for the complications or feel inadequate. And this, again, exacerbates the emotional distress. The whole trauma event can lead to sleep disorders and sleep disturbances, and things like insomnia and fragmented sleep are very common, and this further impacts on the overall mental well-being of these women. If we look at physical impacts, things like chronic pain can result because some of the injuries that are sustained during traumatic birth, such as severe perineal tears or complications, can lead to chronic pain, and this pain can affect the daily activities and overall quality of life. And we've heard pelvic floor disorders. This in itself can be so debilitating. You end up, with things like urinary incontinence, pelvic organ prolapse, and sexual dysfunction, as we heard earlier. And these issues can be persistent and require long-term management. And just the feeling of fatigue and physical exhaustion, trauma just prolongs this, and recovery may take much longer, especially if there was associated significant blood loss or other complications as well. And the duration and persistence of these physiological and physical impacts can vary. Psychological effects like PTSD, anxiety, and depression can last for months or even years if they're not properly addressed through early intervention and continuous support. Physical impacts such as chronic pain and pelvic floor disorders may require ongoing treatment and rehabilitation. And the persistence of these effects is often exacerbated by a lack of timely and adequate support, cultural stigmas, and limited access to specialised mental and physical healthcare services. Just looking, next slide, please. And I'll just go briefly through this. So you can have short-term effects, and these, as I've said earlier, these are physical injuries, may heal within weeks to months, but immediate psychological impact can also start to show within this period. Long-term impact of psychological effects such as PTSD, anxiety, and depression can persist for years if untreated, and physical consequences like chronic pain or sexual dysfunction can also be long-lasting. Next slide, please. So what is help, support, and treatments available? So women experiencing birth trauma have access to various forms of help, support, and treatment, and they aim to address both the psychological and physical impacts. Psychological support includes therapies like cognitive behavioral therapy, or CBT, and eye movement desensitization and reprocessing, or EMDR, which are effective in treating PTSD and other trauma-related disorders. And additional counselling and support groups, such as those offered by the Birth Trauma Association, provide emotional support and a sense of community, helping women process their experiences and can help reduce feelings of isolation. Physical support includes medical treatments for pelvic floor that have been sustained during childbirth, for instance, pelvic floor physiotherapy, and this can help women recover from injuries and manage conditions like incontinence and pelvic floor prolapse. For women from diverse backgrounds, culturally sensitive care is crucial, and this includes providing language support services and cultural competent healthcare providers to ensure that all women receive respectful and effective care. And we have community-based initiatives within maternity, such as the UK's Maternity Voices Partnerships, that work to incorporate diverse perspectives in maternity care planning and to ensure that unique needs of ethnic minority women are met. Next slide, please. And again, I've identified that it is so important to have tailored care for women from diverse backgrounds, and this will help reduce the inequality gap in maternal health care, and ethnic minority women face disproportionately higher risks of birth trauma, as we have said earlier, and adverse outcomes. And it is largely due to systemic inequalities in healthcare access, quality and cultural competence. And we know that cultural competency care involves healthcare providers needing to be trained to understand, respect and respond to the cultural and linguistic needs of diverse populations. And this includes providing things like proper translation services and employing bilingual staff to ensure that there is effective communication. And we know that language barriers can significantly impede a woman's ability to understand her care options and make those informed decisions. Next slide, please. So thank you for listening on my presentation on birth trauma and the pressing need to address inequalities in maternal health care. I have explored, the multifaceted causes of birth trauma and medical interventions and labour and complications. And many of these services are developed using the Eurocentric lens, but it is very important, as I've said, to have services tailored around the communities in question so they can provide that culturally appropriate care. Thank you.
Well, thank you very much indeed, Nafisa. I'm sure the audience, if they could all have a voice here, would be saying thank you as well. And thank you for such a comprehensive and also well-organized presentation. It's lovely when it's the slides, and when I say they're simple, I don't mean that they're not effective, but very simple, and they really gave us a message. So thank you for that. Now, I have some questions that I'd like to pose to both Nafisa and to Geeta. And then there are 1 or 2 questions in the chat that I think would be particularly interesting for us to review. So firstly, I think this really is a question to Nafisa. Can birth trauma be prevented, and how should we be doing it? So let's start with the professionals thing, and also whether there are any personal or family issues that we can help with as well.
Just thank you for that. Birth trauma can be mitigated and in many cases prevented through a combination of proactive healthcare practices, improved communication and systemic changes in maternity care. And we know that the latest evidence does emphasize the importance of respectful patient-centered care and also informed decision-making during childbirth to reduce the risk of trauma. And one of, I think, the key preventative measures is implementation of evidence-based guidance and training for healthcare providers so that they can recognize and manage timely and effectively, signs of trauma before they become, massive and requiring sort of great intervention. And we need to be things like personalised care plans and individualised care, this can help sort of prepare and plan ahead so that women also understand what could happen and what things not to do and what steps could be made to help minimise this.
Yes, thank you. Gita, you had your hand up.
Yeah, I was just from a patient perspective, you know, traumatic birth cannot always be prevented. I mean, that's the, you know, the nature of obstetrics. There's scenarios when things can't be planned or things can become an emergency. But what we can do is to reduce the impact of birth trauma on mothers. And I think the way that we do that is vitally good communication, information to mothers, and empathy. Those are the things that can reduce the impact of a traumatic birth on a mother. I think antenatally, you know, antenatal education is absolutely key. We need to be, you know, going back to having antenatal information for women, especially first-time mothers, so that they can be aware of different scenarios that might happen. You know, women can't, you know, be presented with a pair of forceps or told about forceps for the first time during a delivery. You know, information, education empowers women so that they can advocate for themselves. And also, I really think we need to be listening to the women at the heart of these services and seeing the woman in front of them. You know, I know every healthcare professional comes into practice every day wanting to do the best. But sometimes you don't necessarily see the woman in front of you and as an individual. And I think it's about treating women with compassion and respect. And as I said, keeping them informed of what's happening, because those, you know, it's not small things, but they can have such a huge impact on maternal outcomes.
I think that you're very generous when you're saying, you know, doctors and midwives don't get up in the morning and say, I'm going to go and harm somebody. But as you rightly say, and I think I must say this as an obstetrician by training, that, you know, we sometimes get it very badly wrong, and we're not empathic enough, and we're not understanding enough, and we're not personalized enough. And that we really do have to focus on that. And I think there's an enormous amount of work going on with my sort of alma mater, which is the RCOG and the Royal College of Midwives as well, to have multidisciplinary training in OAC, prevention, obstetric anal sphincter injuries. I think that's a very, very important point. But also, I was very struck by listening to some of the testimonies that were produced in Parliament recently about birth trauma and PTSD. And I was very struck by your comment that, you know, you can't always prevent things and that things can be unexpected in obstetrics. I often say to women when I'm talking to them and to my trainees, you know, sometimes you have to accept the fact that the final decision is going to be made by the person with the least experience, and that's the baby. And sometimes things just happen. But I think that the testimonies I've heard from you, Gita, and what I've discussed with Nafisa in the past and with many other women over my career is that it's not so much the injury, it's when that injury is not recognized, or it is dismissed, or it's minimalized, or it's trivialized. And that is where the trauma comes in. And I think that you would have understood and had a much, much smoother recovery if somebody had said, oh my goodness, she's got a 4th degree tear. We're going to get the colorectal team in if we haven't got an experienced gynecologist here who's got specialist skills in this, and then followed you up regularly, rather than what you described as you having to limp literally along to see people and ask them to pay attention to your problem.
Absolutely, absolutely, Leslie. So, you know, it is multifaceted. So it is about, you know, during the actual delivery, being treated empathetically and with kindness and good communication. That's key. And then secondly, if an injury does occur, exactly, for it to be recognized and repaired. But then also, you know, very quickly you're out of that, you know, primary setting and you're referred on. So it's about then smooth pathways, clear for whatever injury a woman sustained. So for example, for me, had there been a clear perineal, my injury, you know, I had a 3C tear actually, had that been, you know, I'd been referred to a perineal trauma pathway, I, had gone to see, colorectal or pelvic health specialist physio. I would have felt held and supported. I would have understood what was happening to me. And I would have, there would have been a clear pathway then to treatment, potential treatment. Whereas what happened is there was absolutely no support. So I was discharged into the community, seeing my GP, who, as I say, literally, he was very, very empathetic. But he used to say to me, "Oh my God, I've never heard of such awful kind of symptoms." And that actually just, such an awful story makes you feel worse, because it makes you feel like you're completely alone. So you're isolated, you're alone, you're trying to care for a newborn baby. Sometimes they have injuries as well. So that postnatal support is, I'm all about prevention, Leslie. Let's prevent the injuries and the trauma if we can. But if not, it is about supporting those women afterwards, postnatally.
I agree. And also the importance of pain relief. And that may seem a very obvious thing, but if you're in pain and you haven't got good pain relief, or someone hasn't recognized that you perhaps can't really talk about it, but you are obviously traumatized. I mean, I think I can recognize somebody in pain, but it is so important. And it's also such a confidence builder for that woman and also her partner. I mean, I think the number of times I've seen male partners, or female partners for that matter, getting really quite angry and quite aggressive because they feel disempowered because they can't protect this woman who's in pain. And so there are all sorts of ways that I think that we really do have to look at all those issues. Nafisa, what resources can women and men go to try and reduce the incidence of or prevention of birth trauma, and also to cope with it if they're unlucky enough to experience it? Where should women go to?
So, as I said earlier in the presentation, there are associations out there. I mean, within many trusts, you have the psychological support and counselling facilities that provide CBT and EMDR, and the CBT really helps women sort of process their birth trauma experiences, changing negative thought patterns into sort of changing that sort of mindset and trying to sort of process the whole event. They can, many of our trusts also, after having a birth trauma, they get debriefed by the midwifery and obstetric team, so they can actually process what actually happened, what happened in that pathway, so they can fully understand, because many women think, is it my fault, and did I do anything wrong? But at least they can discuss with the healthcare providers, from start to finish what happened. As Geeta said, sometimes you can't always prevent traumas, they can happen. So at least she can understand that, and that is available out there as well. And also there are support groups out there, for instance, like the Birth Trauma Association, where women can share their experiences and receive emotional support from others who have gone through similar situations as well. And I think also it's very important, and Geeta has highlighted this, that to have family support, to have your sort of loved ones as well understand what you are going through. So it's about having that there, because having to cope with this sort of thing on your own, it's really hard. But again, we're talking about support for the woman, but I think it's very important to have support for the partners and also for the wider family, because it's huge, isn't it? They're seeing their loved ones go through this. She can't bond with the baby. She's not maybe behaving in that way that she usually does. Pain, as you rightly said, I know what pain is like. I've experienced pain. And when you are in extreme pain, nothing else matters, because you're trying to survive. You're just trying to survive, and you are not aware of what's around you. You can be, aggressive or whatever, but that's not you, because you are literally trying to survive that pain. So it's so important to have those processes, that support and that pain management, good pain management in place.
So we've got.
I would always, sorry, Leslie, I was just going to add as well, I think what also is really helpful is, when a woman is ready, is that peer-to-peer support. That's absolutely what I found to be most helpful. It was many years later. It wasn't until I actually helped support the start of the Amazing Foundation. And it was the first time ever, I think 2015, 2016, so 7-8 years after my injury, that I'd met a group of women who had understood what I had been through. And it was, it was a turning point for me. And in fact, very often, the women who have been through this physically or psychologically, they're the ones that actually hold the best information and the key about, about treatment and what works. I've learned so much from my peer support group. We have a big WhatsApp group on MASIC and the Birth Trauma Association. And, it's very sad that every day new women join and their stories are shared, but also the support that's provided, but also the practical help.
Good.
Is phenomenal.
That's going to bring several of the two important questions that I'm going to bring together here. And that is the request to have practical tips of how we can cope during maternity leave. So MASIC and the Birth Trauma Association and any postnatal groups that you may have more locally to you. And I'd also like to come back to a comment that one of the gentlemen on this call, and thank you to Guy Topping for joining us. He's asking, what can we do in the workplace to improve employer awareness? And if we were to, because you described a very good experience with your law firm, Gita, but that's not common. So what workplace adjustments, what would they look like? So let's start with that one, and then we'll come back to the other practical tips. So we've got peer group support, we've got ensuring that the healthcare professionals are much better versed in what the problem is, multidisciplinary care. You need physios and OT people and colorectal people, as well as gynecologists and obstetricians. But just giving you a few moments to think about that employer awareness. What do we need to get employers to do, to be aware of at the time, and also what are the longer term measures that they may need to put into place to support that woman when she can come back to work?
Well, I mean, I think, with the kind of with the information that is out there about birth trauma now, following the National Birth Trauma Inquiry, it's in the press. So the conversation and the awareness has definitely increased. So in terms of employers, the statistics are shocking about the number of women that suffer from birth trauma. So I think, education is key. Different employers being aware of the statistics, that 50 or more percent potentially of their workforce, at their own policies. But I can only really speak to my experience. My firm always kept the door open, and when I felt like I needed, I was able to return, I've been fully supported. And that support has looks like working from home predominantly, because obviously with my bowel incontinence, it's difficult sometimes to, come into the office. Flexibility of working. So I work flexibly across the week. And, when I do go into the office, things like, being able to access the bathrooms frequently, as much I sit near the bathrooms. So adjustments like that.
Thank you. That's really helpful. And in the longer term, and what should they be looking out for?
Well, I suppose sorry, Leslie.
Nafisa,
yes, please do
as well.
So I'm going to talk about the sort of the trust aspect, because I think it is very important, and I know they are implementing, it's part of the 3-year delivery plan to ensure that we have pelvic floor services in place. But it's about ensuring that, yes, you have a service, but you co-design it with the women. So it's talking to women who have been through already these horrendous experiences and understanding what the gaps were and how we can improve the services to meet those needs, and thinking about employment, thinking about appointments, debriefing, and all those things that are required to ensure that these women don't feel excluded, don't feel dismissed, but are actually listened to. So I think that is key to have, co-design and co-production.
I'm so glad you've mentioned that, because as anybody who knows me in my women's health ambassador role, I'm constantly going on about we've got to stop telling women what they need. We've got to actually ask them what they want and listen to that and help them to access the services in the way that they need to. Several people have been wondering how they can join the WhatsApp group, and Jen Hall is here from the MASIC Foundation, and she's put in the chat. You can email them info@masic.org.uk, and that Jen Hall and her team will help you join the WhatsApp and Facebook support groups that MASIC are involved with. So please take up that opportunity. I'd also like to mention another practical tip, and that is one of our, I think it was Maria War that said on the chat that she was greatly helped by developing an emotional well-being birth plan for her next pregnancy. And her concern was that no one would listen to it, but she felt that she really was given a lot of listening time and a lot of empathetic help, and that she really did receive trauma-informed care. So I think that's important. And then you will find as well that in the Department of Health websites, there are quite a lot of guidelines and standards for trauma-informed care, not just for birth trauma, of course, but for trauma post abuse and all sorts of other things, which I think are really, really important. So I'm drawing towards the end of this. Protected time to attend appointments from employees, Pauline is saying to us. And I think that's also a very important point. And better research and peer support. We're going to work on all those. Protected breastfeeding facilities, better maternity and paternity services. And as you say also, we need to ensure that this is a universal thing across the country, that it's not just in centres of excellence, that everybody's going to need this sort of help. So I'm going to thank our two wonderful panelists. I'm going to thank the audience as well, who really asked us some very interesting questions, and I hope that they've enjoyed the responses. As I say, please make use of all the links that have been put into the chat and offers of help. And I think I'm going to end as well with a plug for one of Wellbeing's current campaigns to increase the numbers of employment firms that have joined the employer membership program, where you'll be able to access all sorts of materials and resources and aids to help you treat the women that you're employing in your firms even better. And I really would think that's a very, very important thing to do. Please go onto the Wellbeing of Women website. And I've already asked Geeta to make sure that Erwin Mitchell sign up to the EMP program. And Nafisa and I are going to find ways in which we get the NHS, which is the largest employer of people in Europe, 80% of whom are female, to do this too. So can I thank you all again? It's been a pleasure to be here. It's one of my great privileges as the chair of Wellbeing of Women, is being able to be here and to welcome our guests and to field some of the questions. I really do think that it's helpful, not just to the women on the platform today and our audience, but to many others who will source this information later. And I can't wait till the next month's webinar. So thank you again and have a lovely rest of the day. Bye-bye.
Thank you. Bye-bye.